Good day, everyone. Today's lecture will be on antibiotics in oral surgery. This lecture will cover the introduction, etiology of oral infection, treatment principles, antibiotic consideration, proper antibiotic administration, prophylactic antibiotic therapy and principle of prophylactic antibiotic use, prophylaxis antibiotic regime, and a summary of the National Antibiotic Guidelines 2000. Let me start the lecture by defining what is infection. Infection can be defined as the invasion and multiplication of microorganisms such as bacteria, virus, fungus, and parasite that are not normally present within the body. An infection may cause no symptoms and be subclinical, or it may cause symptoms and be clinically apparent. Three factors are necessary for an infection to occur: source of infection, susceptible person, and transmission mode. Example of source of infection is infected person or susceptible person. Those with compromised immune system have an increased susceptibility to chronic or persistent infection. Those individuals who have a suppressed immune system are particularly susceptible to opportunistic infection. Infection can be transmitted by droplet, sexual transmission, or vector-borne transmission. The signs and symptoms of an infection depend on the type of the disease. It can be generalized or localized. Generally, an infected patient may look fatigued, may have loss of appetite, weight loss, may experience fever and pain. Local signs and symptoms is specific to individual body parts such as skin rashes, swelling, and trismus. An infection is not synonymous with an infectious disease, as some infections do not cause illness in a host. So what is oral infections? These are a group of infections that occur around the oral cavity. It may be odontogenic origin or non-odontogenic origin. Oral infections commonly present with symptoms of pain, fever, and odontogenic infections are the most common infection of the oral and maxillofacial region. It originates from the tooth and the tooth supporting structure. Caries tooth, periodontococcus, and pericoronitis are the causes for odontogenic infections. It may range from low-grade and well-localized to severe, life-threatening deep facial space infection. Odontogenic infection is polymicrobial in nature. 5% of the bacteria are aerobic bacteria, 35% are anaerobic bacteria, and 60% are a mixture of aerobic and anaerobic bacteria. The lower teeth are the most common source of severe odontogenic infections than the upper teeth, with the mandibular third molar as the origin in the majority of cases. Odontogenic infections proceed through three stages: inoculation, cellulitis, and abscess. So what is the difference between abscess and cellulitis? Abscess is localized area of inflammation containing pus, whereas cellulitis is the diffuse inflammatory reaction which spread through soft tissue spaces and along facial plane. This is the characteristic difference between cellulitis and abscess. Cellulitis is an acute process which takes about 2 to 5 days, whereas chronic abscess is a chronic process which takes about 4 to 10 days. Patients with cellulitis will experience severe pain, whereas patients with abscess will experience more localized pain. In terms of size, cellulitis has diffuse border, whereas abscess has a well-localized border. In terms of palpation, cellulitis appear to have duffy to indurated texture, whereas abscess tend to be more fluctuant. There is no pus in cellulitis, whereas you have accumulation of pus in the abscess. In terms of bacteria, cellulitis have a mixed aerobic and anaerobic bacteria, whereas for abscess it's strictly anaerobic bacteria. So the common pathogens in odontogenic infection can be grouped into aerobic gram-positive cocci, for example Staphylococcus and Streptococcus, aerobic gram-positive bacilli, for example, lactobacillus and corynebacterium, anaerobic gram-positive cocci, peptococcus and peptostreptococcus, anaerobic gram-positive bacilli, for example, actinomyces and clostridia, and the anaerobic gram-negative bacilli, for example, bacteroids, fusobacteria, and prevotella. The pattern of spread is predictable depending on the relationship between the point of attachment of the adjacent muscle and the tooth apex. Infection will follow the path of least resistance through connective tissue and along facial plane. From here, the infection may diffuse quite distantly from its dental source, causing damage to the surrounding structure. The mode of spread can either be direct or indirect. Infection can spread directly into superficial soft tissue, into adjacent facial spaces, and the infection can also directly spread into the deeper medullary space, producing a spreading osteomyelitis. Indirectly, the infection can spread through the lymphatic route, via the lymphatic routes to the regional nodes, and also hematogenous route, which can go to other organs, for example, the brain. The two major origins of odontogenic infection are periapical and periodontal origin. This will start with flow by hydrostatic pressure, then it will follow the path of least resistance and spread through cancellous bone until the cortical plate. And if the plate is thin, infection will erode through the bone and enters the surrounding soft. This diagram to show a relationship between the tip of the root or the apex of the root and the thickness of the overlying bone. The spread of infection will follow the path of least resistance. So here you can see the infection will go towards the area of thinner bone. Here you can see we will go to the labial area instead of the palatal area, because the palatal area is more thicker. This diagram to show the relationship between the apex of the root with the muscle attachment. If the apex is below the muscle attachment, the infection will spread intraorally. And if the apex is beyond the attachment of the muscle, it will spread extraorally. There are three major anatomical spaces involved in odontogenic infection. The first is maxillary space, which include the canine or infraorbital space, the buccal, and infratemporal space. The second anatomical space is the mandibular space, which includes submental, buccal, submandibular, and sublingual space. And the third anatomical space involved is the facial spaces, which include mesenteric space, trigomandibular, retropharyngeal, lateral pharyngeal, and superficial and deep temporal space. An odontogenic infection can progress to form Ludwig's angina, deep facial space infection, orocutaneous fistula, cavernous sinus thrombosis, and can also lead to the formation of osteomyelitis. These are the principles of treatment for odontogenic infection. Determine the severity of the infection. We need to evaluate the host event. Then we need to decide on the setting of care. Then treat the infection surgically, support medically, and we need to evaluate the patient frequently. Early recognition and management of orofacial infection is mandatory. The treatment of odontogenic infection is based on two fundamental elements: mechanical surgical management and antibiotic therapy. The majority of this infection is self-limiting and may drain spontaneously. And due to the proximity of the central nervous system and the respiratory passages, timely efforts are required to establish a pattern airway, mechanical debridement, drainage, and appropriate antimicrobial. Surgical incision and drainage may obviate the use of antibiotics or may increase the effectiveness of the antibiotics as the vascular flow is restored, decompress the edematous tissue, as it allows better perfusion of blood and increased oxygenation of the infected area. The antibiotic in use should be active against both aerobic and anaerobic bacteria. And the antibiotic prescription is empirical and based on the clinical condition of the patient in some individuals. So the first principle of the management of odontogenic infection is to determine the severity of the infection. This may include the taking of complete history, which include chief complaint, onset of the infection, cause of the infection, the rate of the progression, the symptom, and the previous treatment that has been given. So clinical assessment may include complete history, physical examination, clinical features, laboratory investigation, radiological investigation, and interpretation of all the findings. So physical examination may include the assessment of the vital sign. The temperature may go more than 38 degrees Celsius. The pulse may go more than 100 beats per minute. BP may be high because of pain, and it can also lead to septic shock, which will lead to hypotension, and respiratory rate will be elevated. A patient will look fatigued, feverish, toxic appearance, and dehydrated, and a good extraoral and intraoral assessment is required. The second principle is to evaluate the host defense. We need to evaluate the medical condition that compromise proper function of the immune system. For example, those with diabetes, those on steroid therapy, with malignancy, those under chemotherapy, or those with malnutrition. Then we have to decide setting of care, whether to do it under local anesthesia or general anesthesia. Most odontogenic cases can be managed under local anesthesia, but for some cases they are life-threatening and require management under general anesthesia. What are the indications for hospital admission for odontogenic infection? Those patients with high temperature that is more than 30 degrees Celsius need to be admitted. Patient who shows signs of severe dehydration need to be admitted. Patient also need to be admitted if there's a threat to the airway or vital structure, when there is involvement of the moderate or high severity anatomical spaces, and when there is a need for inpatient control of systemic disease. The fourth principle is to treat the infection surgically. The goal is to remove the source of infection and to provide drainage for accumulated pus and necrotic debris. The surgical care may include pulp extirpation, tooth extraction, or incisional and drainage. And the fifth principle is to support the patient medically. So there's a need to control any existing comorbidity or systemic diseases, need to rehydrate the patient, correct the electrolyte, provide a proper nutritional status, good analgesic, proper antibiotics. We need to give a proper antiseptic mouthwash and provide a good post-operative instruction for safe care. And the final principle of treatment of the odontogenic infection is to evaluate the patient regularly. Right, so what is antibiotics? Antibiotic can be defined as naturally produced substance that can inhibit growth of microorganisms. It is usually produced by other microorganisms. Antimicrobial, on the other hand, is synthetic substance that can inhibit growth of microorganisms. It has increased spectrum and better pharmacokinetics. Antibiotic has its own medical uses. It can be used for therapeutic purpose or prophylactic. So therapeutically, it can be used to treat an existing infection or to treat an unknown infection. Prophylactically, it can be given to prevent infection following a surgical procedure or to minimize the risk of infection following a procedure. Prophylactically, also it can be given due to patient or procedure related. So these are the indications for prescription of antibiotic. Acute onset with diffuse swelling and moderate to severe pain. It should be given to patient with medically compromised. Should be given when there is an involvement of the deep facial spaces, when there is severe pericoronitis, when there is evidence of trismus, when the temperature is higher than 38 degrees Celsius, and when there is evidence of osteomyelitis. Antibiotics are not indicated on patient demand. Severe pain, toothache, periapical abscess, not indicated for dry socket, not indicated for multiple dental extraction in a patient who is not immunocompromised, not indicated for mild pericoronitis or drain alveolar abscess. In order to reduce the complication of unnecessary antibiotic prescription, especially due to bacterial resistance, a comprehensive guideline should be established. We should consider the use of antibiotic with the lowest incidence of toxicity and side effect. And it is very important to remember that most antibiotics have a variety of toxicities and side effects that limit their usefulness. Antibiotic prescription may result in some adverse effect. For example, it can cause hypersensitivity reaction, it can cause dermatological and allergic disorder, bacterial resistance, it can cause gastric discomfort, it can cause hematological problem, it can cause diversion of bacterial microbiota. What are the considerations in giving antibiotics? We should consider the use of narrowest spectrum antibiotic. It is preferable to use an antibiotic with the narrowest spectrum that is effective against the organism involved in the infection. The use of broad spectrum antibiotic should be avoided because it increases the risk of the development of resistant microbial strain and also increases the risk of superinfection by disrupting the normal bacterial flora in various body cavities and permitting ordinarily non-pathogenic bacteria to proliferate and cause disease. The use of bactericidal antibiotics. Antibiotics may either kill bacteria or interfere with their reproduction. Bactericidal antibiotics usually interfere with cell wall production in newly forming or growing bacteria. Bacteriostatic antibiotics, on the other hand, interfere with bacterial reproduction and growth. This slowing of bacterial reproduction allows the host defense to move into the area of infection, phagocytose the existing bacteria. So bacteriostatic antibiotics will require reasonably intact host defense. For patients with compromised host defenses, bactericidal antibiotics should be the drug of choice. So what is the principle of antibiotic usage? There are four principles: choice, dosage, route, and duration. Choice can best be determined using culture and sensitivity, but for most of odontogenic infection, we give empirical antibiotic, meaning the most common antibiotic given for that specific condition. And then dosage is depend on the body weight. Route can either be orally or parenterally, and duration depend on the severity of the infection. The antibiotic choices in maxillofacial surgery should cover the common organism involved. The aerobic gram-postecocci, anaerobic gram-postecocci, and the anaerobic gram-negative rod. There are 5 mechanisms of action of the antibiotics. Inhibition of cell wall synthesis. Some antibiotics may cause alteration in cell membrane integrity. Some may inhibit ribosomal protein synthesis. Some may inhibit the nucleic acid synthesis, and some will inhibit the folic acid synthesis. Inhibition of cell wall synthesis. The principal inhibitor are the beta-lactam antibiotic and glycopeptide, for example, penicillin and cephalosporin. And the antibiotic which causes alteration in cell membrane integrity actually disrupt cell membrane osmotic integrity by causing voids to form in the membrane and displacing divalent metals from membrane lipid phosphatase, for example, polymyxins. Inhibition of ribosomal protein synthesis may include or may involve the prevention of the initiation complex necessary for bacterial translation. Example of antibiotic are those of macrolides, tetracycline, aminoglycoside, and lincosamide. Antibiotic can also inhibit nucleic acid synthesis. For example, metronidazole, and fluoroquinolone. Antibiotic also can inhibit the synthesis of folic acid, for example, sulfonamides and trimethoprim. Microbial resistance to antibiotic has become a major factor in determining when and which antibiotic is used, as well as dosage and length of administration. Example of bacterial methicillin-resistant staphylococcus, Streptococcus pneumonia, and enterococci. Bacteria develop antibiotic resistant mechanism by a certain mechanism. They can they can cause enzymatic antibiotic inactivation. They can cause modification of the target cell. They can limit access of the antibiotic, meaning they can alter the cell membrane permeability. They can cause active drug efflux. They can cause failure to activate the antibiotics, and they can also cause overproduction of target sites. Okay, these are the commonly used antibiotic in dentistry: penicillin, amoxicillin, ampicillin, metronidazole, erythromycin, cloxacillin, clindamycin, and penicillin are bactericidal beta-lactam antibiotics that inhibit bacterial cell wall synthesis. These groups are effective against aerobic gram-positive cocci and many gram-negative oral anaerobes. However, there are increasing number of resistant strains, Streptococcus, which alter the binding site, and anaerobic, which can produce beta-lactamase. Resistance are more frequent in patients who had recently received course of penicillin. Amoxicillin and ampicillin. This group has a broader spectrum than the penicillin. It includes enterobacter. It includes effect on enterobacteria. Amoxicillin and ampicillin are bactericidal. It has a better oral absorption than the penicillin. And in terms of resistance, it is less widespread. And amoxicillin and ampicillin are the primary choice for endocarditis prophylaxis. Metronidazole is effective only against Strix anaerobe. It is a bactericidal antibiotic. It needs to be used together with agent effective against aerobe. Resistance not very widespread. It can be very useful in acute necrotizing ulcerative gingivitis and also pericoronitis. Erythromycin has a good spectrum for oral bacteria and beta-lactamase resistant. It is primarily bacteriostatic, but it has a bactericidal at high concentration for some gram-positive species. However, erythromycin has problem with absorption, create GI disturbance, and resistance. No longer recommended by AHA as alternative to penicillin for infective endocarditis prophylaxis. It is used for specific respiratory tract infection. We have new generation macrolide such as clarithromycin and azithromycin. Cloxacillin is resistant to destruction by beta-lactamase. It has certain degree of bactericidal activity. It has less activity against aerobic gram-positive, for example, Streptococcus pyogenes, and it is used specifically for beta-lactamase producing Staphylococcus aureus. Clindamycin is a lincosamide antibiotic with bacteriostatic properties against several obligate anaerobes. It has good spectrum for dental-alveolar infection. It is an alternative to penicillin for infective endocarditis prophylaxis. However, it is not easily available. Cephalosporin is a beta-lactam antibiotics that are closely related both structurally and functionally to the penicillin. Cephalosporin is bactericidal. It is more resistant than penicillin to beta-lactamase. Example, cefuroxime, which is a broad-spectrum cephalosporin, often used in combination with metronidazole, can be given orally, well absorbed, and active against beta-lactamase producing. So now let us look at antibiotic prophylaxis. What is antibiotic prophylaxis? It's the administration of an antibiotic before a dental procedure to minimize the risk of bacterial infection. It is only given when the risk of infection is high due to high incidence of bacteremia. It is, it is good to remember that infection can occur at a distant site through the hematogenous route, for example, endocarditis, and infection can also occur at an oral surgical site, for example, after dental-alveolar surgery. Antibiotic prophylaxis should be given just before the surgical procedure. The aim is to achieve high plasma and tissue contamination at the time contamination is more likely. Antibiotic prophylaxis is indicated for surgical site infection, indicated for surgical procedure that lasts longer than 3 hours, indicated in medically compromised patient, those with implanted prosthetic device, and indicated for those with life-threatening infection, for example, infective hepatitis. In minor oral surgery under local anesthesia, for example, surgical extraction, biopsy, and episectomy, the rate of post-operative infection is low. So the use of antibiotic prophylaxis have little or no effect. When we look at surgical site infection, the risk of post-op infection for clean surgery is only about 1 to 2%. For clean contaminated surgery, about 6 to 9%. Risk of post-op infection for contaminated surgery about 10 to 20%, and for dirty surgery about 40%. So prophylaxis is indicated in contaminated and dirty surgical procedures, and also depend on the fitness of the patient and duration of the surgery. What about antibiotic prophylaxis in the management of soft tissue trauma? Antibiotic prophylaxis is not recommended for laceration wound, which is not extensive, visibly clean, and treated within 3 hours of injury. However, antibiotic prophylaxis is indicated for laceration wounds that are extensive, visibly clean, and treated within 3 hours of injury. Laceration wounds that is seen within 3 hours of injury, but delayed treatment is expected. Antibiotics should start immediately and continue until definitive treatment with last dose at the end of the treatment. For laceration wound, which is more than 3 hours of injury or visibly contaminated at the time patient first seen, should be treated as an established infection. So, who is at risk of developing infective endocarditis? Those patients with acquired valvular heart disease with stenosis or regurgitation, those that need valvular replacement, those with structural congenital heart disease, including surgically corrected or palliated structural condition, those with previous infective endocarditis, and those with hypertrophic cardiomyopathy. These are group of patients who do not require prophylaxis. Those with pulmonary stenosis, those who have surgically repaired ASD, VSD, and PDA, those who have undergone coronary artery bypass graft, those with mitral valve prolapse without regurgitation, and those who have cardiac pacemaker and defibrillator. These are the dental procedures requires prophylaxis for infective endocarditis. Extraction, periodontal procedures including surgery, subgingival scaling and root planing, replanting of avulsed tooth, or other surgical procedures, for example, implant placement and episectomy. Prophylaxis are not indicated if we are giving infiltration and block local anesthetic injection. It is also not indicated for supragingival rubber dam clamping placement, not indicated when you are doing intracanal endodontic, or when you are doing suture removal, or when you are taking impression and construction of denture, and when you are doing supragingival plaque removal. So the prophylactic regime for infective endocarditis, you can either give amoxicillin 2 gram 1 hour before procedure for adult, or 50 milligram per kg for children. Or if the patient is allergic to penicillin, can give clindamycin 600 milligram 1 hour before procedure, or for children 20 milligram per kg. prophylaxis antibiotics should follow guidelines wherever available. Important to realize that there is no benefit or very less benefit in minor oral surgery. It is only indicated in some situations, and we need to evaluate each case individually and prescribe if you can reasonably justify it. So this is the antibiotic regime for oral infection. For superficial odontogenic infection, for example, involvement of canine or buccal space infection, you can prescribe oral pinoxymethylpenicillin 500 mg 6 hourly for 5 days, or you can prescribe oral amoxicillin 500 mg 8 hourly for 5 days. And if the patient is allergic to penicillin, you can prescribe oral clindamycin 300 mg 8 hourly for 5 days. For unresponsive superficial infection, you can give metronidazole orally 400 mg 8 hourly for 5 days, plus either pinoxymethylpenicillin 500 mg orally 6 hourly for 5 days, or amoxicillin 500 mg orally 8 hourly for 5 days. If patient is allergic to penicillin, you can give clindamycin 300 mg orally 8 hourly for 5 days. For deep facial space infection, you can give metronidazole 500 mg IV 8 hourly, plus either IV benzylpenicillin 1.2 gram 6 hourly IV, or amoxi or ampicillin 2 gram IV 6 hourly. And if the patient is allergic to penicillin, you can give IV cefazolin 2 gram 8 hourly. So all patients with infection should be reviewed within 48 to 72 hours of commencing treatment. If the infection has not yet resolved within 5 days, do not just repeat the antibiotic. You should check that any pus has been drained, the cause has been removed, the appropriate antibiotic is being used for the particular microbial susceptibility, and the patient's general condition and medical situation are being managed accordingly. So the last few slides will show you the summary of National Antibiotic Guidelines 2008. According to the National Antibiotic Guideline 2008, systemic antibiotics are not indicated in the case of reversible or irreversible pulpitis, localized dentoalveolar abscess, dry socket, localized pericoronitis, also not indicated in chronic gingivitis and chronic periodontitis. However, it is indicated for aggressive periodontitis, where we can give amoxicillin plus metronidazole. Localized periodontal abscess is also not indicated for systemic antibiotics. For infection of the jaw, for example, osteomyelitis of the jaw of dental origin, we can prescribe antibiotics. We can give pinoxymethylpenicillin, or we can give benzylpenicillin. For infection of deep facial space, for example, with or without systemic sign, for example, in the case of cellulitis or abscess of dental origin, we can give IV benzylpenicillin plus minus with IV metronidazole. Plus we can give cloxacillin IV or clindamycin if the patient is allergic to penicillin. And if we are giving oral administration, we can give amoxicillin plus minus with metronidazole, or if the patient is allergic to penicillin, we can give clindamycin. And finally, for peri-implantitis, we can give oral amoxicillin plus metronidazole. So antibiotic is indicated for peri-implantitis. Okay. So that is the summary of the National Antibiotic Guideline of 2000. So with that, I conclude my lecture. Thank you.